Thank you very much. My name is Nakazibwe Brenda, and I am from the School of Public Health, Makerere. This study was part of our field placement, and we did it in Lira. It was part of the deliverables for my Masters of Public Health, and those are the co-authors. Background. What's happening? A background. Neglected tropical diseases, where, oh sorry, I didn't give us the title. We did a trends analysis of the prevalence of soil-transmitted health infections in Lira district, and how it fits in our determinants, social determinants for health is we have a number of them. We have sanitation and hygiene, we have the environment where people stay, and you realize that most of these transmitted helminths fall there. So for the background, we in the years, the 1990s and the mid-2000s, we see a decline. We see a decline in transmission of soil helminths, but then this was majorly recorded in the high-income countries and low for the low and middle-income countries. So this study in Lira district found that actually soil-transmitted helminths were the second major cause for morbidities and mortalities. That's why I took interest in STH. Objective of the study, the main objective was to analyze helminth infections in Lira district by place, person, and time, because we know that epidemiology thrives there. Methods, it was really a documents review of secondary data, and we utilized quantitative methods for research. The study population was really all the males and females who presented with soil-transmitted helminths that were captured in the health records of the district. The dependent variable was the prevalence of soil-transmitted helminths, and the independent variables I already talked about, the person, place, and time. We got clearance from the district health office and definitely Makerere School of Public Health. Results: 66% of the risk of the data that we looked at were female, and 34 were male, presenting with soil-transmitted helminths. And STH was higher among males and females of 5 to 59 years of age. The rural sub-counties had more infections than those in the urban. And the prevalence for the 3 years was 5.6% 2015, 5.8% 2016, 6.4%. The descriptives, the way the district health information software DHIS2, where we extracted our data, the way it is categorized by age is 0 to 28 days, 29 days to 4 years, 5 years to 59 years, and 60 and above. The figures are small, but for each of those categories, we had soil-transmitted helminths. Those are the results that I already talked about. So, for our discussion, characteristics by person, females were more affected than males. we realized that females in northern Uganda do more work. They actually work for the men. So which kind of work do? They build houses, they do the farming, they have to take care of the children, and they have a lot of open defecation. So all these actually expose them to soil-transmitted helminths. And on the other hand, definitely the men who sit back and relax and do their local brew, the ajono in the evenings, their exposure is much less. They are the ones who put on the shoes, the rubber shoes, while the women are barefooted in the gardens all over the place. That's the exposure. For females as well, why the system is able to capture them or was able to capture them more is because of the health-seeking behavior. So I believe that could also speak to the numbers we're able to get. The men lay back, they want to fight disease, they are strong, so there's no need for health care. For the age-specific variations, you find that those that were 5 to 59 years were more exposed. We are still looking at person, because really this is the most active age group. Even the lower end of the 5 years, maybe to 15, they are playing, they are doing all sorts of things, while the women, we already catered for them, are working. Time characteristics. We saw a more relaxing downward trend, yes, but also you realize that they are globally, we have strategies in place to reduce soil-transmitted helminths through mass drug administration. And you realize that the preschool going and the school-going children are the most beneficiaries for this. So this could also probably explain the reason for the downward trend. For place, we find that soil-transmitted helminths are associated with poor socioeconomic indicators, like we looked at them, and like each presenter has mentioned, the social determinants of health, the poor sanitation, low safe water coverage. And for our study, indeed, the rural and poor sub-counties of Adiel, Amach, and those other sub-counties are Romo, where we had LRA, the Lord's Resistance Army, disturbing quite a lot. People were in camps, congested. We find that they had a bigger challenge than these in the urban. So we are able to at least see plausibility somewhere there, an association. So that study had a limitation majorly because the DHIS2 data is not delineated by age. It's not well categorized, at least from what I observed. Imagine you have a category of 5 to 59 years. So by the time you want to thresh out where exactly you should intervene better, you find that you are a bit hand-tied. So, conclusion. There was an increasing trend in the prevalence of the soil-transmitted helminths. Much as globally we see a downward trend, but for the district, it is worrying. Remember, I told us that it was the second highest cause for morbidities and mortalities in the district. The burden was highest, indeed, among males and females. What do we recommend to the district health office? Interventions should be made targeting women and people in the rural communities. Health education programs which are very cost effective and yet effective among the people on the causes, symptoms, and case management. And then emphasis should be placed on hygiene and sanitation. And then public health campaigns should really be upheld. And finally, I acknowledge Lira, District Local Government, Makerere School of Public Health, the SPEED project. And I'll end by saying, simple measures, lasting dividends. Thank you. Thank you very much.
Thank you very much, Brenda.